Okay, we have a case submitted. This is from a gentleman who just attended our Ultimate 3D workshop and submitted one of his first cases after he got back to the office to review the plan. One of the things that I'm always really big on is making sure that we have a good plan. So let's take a look. So if we were to evaluate this case, just a little bit of details. The tooth number 19 was extracted in December of 2014. It's now April of 2014, so typically on socket preservations, I like to wait in the 4-month ballpark. So we're right in that ballpark here. So we're ready to rock and roll. So this case, the first question I always have when we look at a case is, what type of guide is this going to be? Is this a classic guide? Is this an opti guide? This is certainly an opti guide. If I were to say, we probably wouldn't use number 18 or number 31 as integration teeth, but the rest of the teeth are certainly fine, and certainly number 3 wouldn't be used either. So in this particular case, we brought in 3D data, so cone beam, and we also have a full arch CEREC scan that is very well integrated. So now we have all the data necessary to go ahead and fabricate an OptiGuide. So in this case, all we're really doing is looking at the plan itself. I went ahead and made a duplicate of the plan so we can compare your plan to my plan if there are any changes that we make. What I also like to do in this situation is go ahead and right click in the 3D skull view and click along active slice, and then I go ahead and lock that in place, so that way as we're looking we can look down and see how everything looks here. So let's go ahead and take a peek. And mesiodistally, I say we look pretty good. Certainly we have enough room. If anything, I would say we have a lot more space to the distal versus the mesial, but that just may be how this site works out. Buccolingually, very nicely placed here. I do have a question on the depth of this implant. The bone has not filled in quite well enough to know whether or not that implant is totally in tissue or not. Sorry, totally in bone. It may be in tissue if there's a little bit of resorption here. So we'll take a closer look at this as we move forward. But that's a minor question I have. If I were to take a look here, the other thing that I see when I look at this is that our implant, our emergence would be, if that's the margin that you want, our implant is outside of that emergence, making this a little bit more difficult to achieve this. So my question is, one, is that what you really want? And then two, was this case planned properly on the CEREC side? And I would say in this particular case, not exactly. And what I mean by that is, if we take a look at our gingival margins of our adjacent teeth and compare it to our implant gingival margin, we can see that our gingival margin should probably actually be more in line with this green line right here to better match the adjacent teeth. So in essence, a small error in the margin drawing will make it look here. So reality is that that tissue margin should probably be about right here. So with that being said, I still may consider moving this implant a little bit to the lingual to give me a little bit more emergence. But based on it being centered, let's leave it as it is for right now. Bone level position, I talked a little bit about that. Personally, depending on your comfort level with guided surgery, I may plan this a hair deeper and then at time of placement back the implant out, or not drive it all the way down to be able to see the bone level position. But that's based on comfort level here. I rather plan deep and then back it out in a case like this, especially when stability, having the full stability isn't that big of an issue, since we're not going to be placing a provisional on there. The next thing we'll look at is the occlusal table. And then looking at the occlusal table here, we can see that our implant is pretty well centered. We can see that it comes through the central groove, so that looks very nice. The other thing that I'll look at with the occlusal table, and I didn't really talk about this in the workshop very much, is I touched on it briefly, is I'll look at this down the line. And what I do know is that molar teeth, lower molar teeth, are typically tilted in. And in this plan, we can take a look here and see that we're actually tilted straight up or even tilted slightly to the buckle. So what I would actually do in this case is probably tilt this implant back like this and probably even move it back out just like that. And now we have a slightly better tilt there. So we'll take a look at that, and then let me take a look at it with the original plan so you can see the difference between the two. So there we go with the original plan, and there we go with the adjusted plan, and that just seems to fit more in line, better along the forces that we'll see there. Now again, that's assuming that this can all be done, and based on what I'm seeing here, that does seem plausible. While I'm on that discussion, this is a case that I would do a crestal incision and move the tissue out, not necessarily a tissue punch. I do have questions in terms of how much keratinized tissue we'll have based on this implant position as we have it here. Okay. Next would be our occlusal plane, and this is where I see a common error. And what I see here is if we look, your upper teeth are like that, your lower teeth are like that, and that's not really exactly what we want. So in this particular case, what I would do is I would need to tilt this a little bit like that. And actually what that does, remember I talked to you a little bit earlier about having, earlier in the video, is having less space on the mesial here versus on the distal. So when we tilt this, that will actually give us a better emergence overall. So we'll tilt this a little bit more, and just like that. So now if we take a look at this here, I will say that, technically I could probably tilt this a hair more. And now let's take a look at my plan versus the original plan, and you can see the slight difference there in that. Okay. Next would be our sleeve, and our sleeve position here. You can see from our movements that we made that now we're hitting the adjacent tooth compared to this adjacent tooth, so we'll just simply move that over. And then we may make a note on to CCAT that we may need to do a little bit of reprox on the adjacent teeth, although right here that looks like it may be some scatter that's making it look that way, because here on the CEREC model we can see that we actually have plenty of space there. So based on what I'm seeing here, everything looks good, just some minor tweaks. So here's a slightly more idealized plan. So we compare that to where we started. The only main difference, to be honest with you, is just the occlusal plane being a little bit more up and down than I would like it to be. So let's try to get it more level. Thank you for submitting, and I hope you found the video useful.